All right, good morning, everyone. Welcome to another AMSSM Sports Ultrasound case series. We're getting towards the end of our fellowship portion of the case series, and today we have um, Lumi, who is a PM&R resident, PM&R physician and a sports medicine fellow. He completed his PM&R residency at Northwestern University Shirley Ryan Ability Lab, where he was the chief resident, and he's currently a sports fellow at NYP Columbia Cornell. Next year, he'll be heading to the University of Washington for an academic sports medicine position. We will be hearing about Popliteus pathology today.
Right. Thank you so much for that introduction. So like you said, I'm Lumi Sokunbi, and today we'll go over the posterior lateral knee pain in a swimmer. The objectives of this talk are to present a patient case, to describe the complete posterior lateral knee ultrasound protocol, to review the ultrasound images and relevant anatomy, discuss pertinent pathology, and to review an official ultrasound report. So getting into the case, I saw a 70-year-old female swimmer with right knee pain for 3 months. She had been swimming for years and first noticed the pain after doing stair climber. The pain was 4 out of 10 in severity, located in her posterior lateral knee, and she described it as sore and a muscle type pain. Primarily, the things that exacerbated it were going down the stairs, extending her knee, and she mentioned doing flutter kicks while swimming. She denied any mechanical or radicular symptoms, took Tylenol for pain, which helped a little bit, had no prior physical therapy, injections, or surgeries, and pertinent past medical history included osteoporosis. Upon physical exam, she lacked 5 degrees of full extension due to pain. She was in a flare-up at the examination point. She had pain at end range of flexion, and she was tender to palpation of the lateral femoral condyle, Gerdy's tubercle, lateral tibial plateau, and the lateral joint line. And of no provocative tests, she was positive for a bounce home test. In terms of initial workup, we had ordered an X-ray and MRI, but in the clinic visit, we were able to perform a diagnostic ultrasound of that right knee. Before we dive into the ultrasound, it's really important to visualize the anatomy in this location with these structures, as there's a lot of kind of crossing over and some overlap and nuances as well. So in this picture to the left, I'll point your attention to some of the main structures we'll go over, which will be the IT band in gray, the LCL in green, the biceps femoris in red. And then to the right, looking at a more posterior view, the popliteus in yellow. Along with visualizing the anatomy, understanding the origins and insertions are helpful because they'll provide landmarks upon ultrasound examination. So of note, the IT band attaches to Gerdy's tubercle, which is that lateral condyle of the tibia. LCL attaches to the fibular head. The biceps femoris attaches to the fibula, and then the popliteus originates from that lateral condyle of the femur and the notch and the posterior horn of the lateral meniscus. So here's the complete posterior lateral knee protocol. We'll kind of dive in, starting with posterior structures and then getting into the lateral components as well. And to optimize your ultrasound examination, we want to make sure we're using the right equipment and positioning. So starting off, having a transducer with frequency ranging from that 5 to 15 megahertz, allowing you to have appropriate resolution and depth to best visualize the structures. For the most part, you can use the linear transducer, but the hockey stick can be helpful for better visualization of nerves. And in terms of positioning, for the posterior knee, you'll have the patient in prone position. And for the lateral knee, you can have 2 options of having the patient supine with a bolster under the knee or side lying with a pillow between the knees, and really thinking about both your ergonomics as well as the patient's comfort. So now starting off with the posterior knee, a great starting place is the popliteal fossa. It's in the posterior knee in this transverse orientation. And as you move distal beyond the knee joint, you'll start to see elements of the popliteus come into view. And it forms the floor of the popliteal fossa as it angles out towards the lateral femoral condyle. So you can see a portion of that in the video here coming in. Next up, sweeping the probe up and down over the popliteal neurovascular bundle, you can demonstrate the popliteal artery, which is typically deep, the popliteal vein, which is in a more intermediate position, and then the tibial nerve, which is superficial, and they are aligned in an oblique sagittal plane. In this prone position, the popliteal vein can tend to collapse and it's very compressible. So a small elevation of the leg from the examination bed and flexing the knee can help fill the vein to enhance its detection. And you can always put on Doppler and kind of assess the flow of the vasculature as well. One key thing to know in terms of pathology is as you move distal and you look and you see the popliteus, it's usually the floor of the popliteal fossa. There's times where that muscle can go on top of the artery and cause some popliteal artery entrapment. So one key thing to note as well. So this diagram is a great depiction of the anatomy of some of these structures. You have your medial head of the gastroc. That asterisk is the medial head of the gastroc tendon. The star is the semimembranosus tendon, and then the arrows are pointing to this light blue area, which is your semimembranosus medial head of the gastroc bursa, which is typically where we find a Baker's cyst. So now looking at the semimembranosus tendon and muscle, you can look in this position, have this orientation and the more medial aspect of the posterior knee, making sure to wag the transducer to correct for any anisotropy, because at times the tendon can look dark versus bright, and making sure you're visualizing as you dynamically scan. And as you go kind of distal, you'll see the semimembranosus dive down. You'll kind of see the medial head of the gastroc having a little bit of a hypoechoic triangular region, which is a portion of its tendon. Next up, looking at the gastrocnemius more closely, you have your lateral and medial heads. You can often start more distal at the mid-calf and get both of those muscles in view, and then follow more proximally and evaluate each one of those. And then this is a picture of it in long axis as well as the lateral gastroc comes in. And then here's looking at the medial gastroc muscle as well on this long axis, with proximal being on the left and distal to the right. And as always with scanning, you always want to make sure to confirm where you are and use your dynamic skills as well, just to evaluate the width of structures to see if you notice any sort of pathology or tears, tendinosis, partial tears as well. So next up, we have some significant nerves in this region. So there is variability in where the sciatic nerve divides. So starting off being in a transverse orientation in the mid-distal thigh with appropriate depth, and making sure you do dynamic scanning so you can evaluate things completely. So at the apex of that popliteal space, the sciatic nerve splits into the tibial and common peroneal nerves. And here, really, you're looking for that honeycomb appearance of the nerve in this transverse view, and you'll be able to see some of the like fascicles that are coming into play from being the hypoechoic spots as well. So here's a video of as you see the sciatic nerve, and then it starts to split into the tibial and then common peroneal right there. I'll play that again as well as you go from proximal to distal sweeping. And then next up now, here's kind of a still shot of that image where you have your tibial nerve here and then the common fibular nerve. At this area, the tibial nerve has a larger size than the common fibular, and then you can follow it straight down towards the origin of through the ankle as well, and then following the peroneal nerve towards the lateral region of the lower leg. So here's following the tibial nerve distally. So it dives deeper. And then now this is showing more of the common fibular nerve as it goes lateral. And this is a nerve where you can have them in this position with them being prone, or you can kind of move them to sidelines. So you can kind of move the transducer laterally and kind of get each checkpoint as you go a little bit lower down. We'll show in a few of these pictures coming up here. So this is a little bit further down as you see in short axis as we're following it as it approaches the fibular head and neck. Another landmark that sometimes is helpful is knowing that the common fibular nerve is found posteriorly to that biceps femoris. So it's another thing you can look for in terms of identifying. And then as we go further, distally, here's it as it approaches the fibular head. And then this video kind of shows it diving deep and curling around that portion too. So next up in this protocol, you can take a look at the horns, the posterior horns of your menisci, as well as the tibiofemoral joint. So starting off, here's an image of the lateral meniscus. So you'll see this triangular structure, usually bright, hyperechoic, as well as sitting in the cleft between the femur and the tibia. The dark area here is going to be some cartilage, so that's normal to expect that in that area as well. And you're really looking for if you see any sort of cyst or major hypoechoic clefts that really don't correct upon like dynamic scanning or wagging and not filling in, so you know that there could be a site of pathology there as well. And then you can move over medially to get the similar view of the posterior horn, but now of the medial meniscus, as well as doing that dynamic scanning. So you have the femur, the tibia, your cartilage, and then you're looking at that structure right in the middle. That's that triangular shape to evaluate your meniscus. Next up, you can visualize the PCL or the posterior cruciate ligament. So this is more deep in the intercondylar fossa. You can really examine the mid-distal portion of the ligament. It's difficult to see the proximal portion of it. And you'll be in long axis in an oblique sagittal plane with the proximal end of the probe rotated slightly medially in the direction of the medial femoral condyle, as we know the anatomical position of that PCL. So you can start to see that here in this image, as well as seeing that deep band of it as we come down, popping through here. And like I'd mentioned, really you're looking for that mid-distal portion of it. It's hard to visualize the proximal just due to the bony anatomy and shadowing. So next up, we're going to look at the lateral knee. And I think a huge thing here is just knowing that these structures are in close proximity and kind of figuring out what's going to be your home base, what's going to be your landmarks, what's going to be your technique. So a common technique that's taught is really this Z configuration. So understanding that I've had it highlighted here where you have your IT band coming down to attach to Gertie's tubercle. Then you have the LCL attaching to the fibular head, and then you have the biceps femoris attaching to the fibula here. So that makes this kind of Z mark, and you can kind of see this surface anatomy wise as well too. And it's really good to have this framework and to visualize this before you put the ultrasound probe on, just so you kind of have that idea of where you're going to be going as well. So now getting into the IT band. So oftentimes to start off, just to show this last slide one more time, you can start off sometimes with the anterior knee scan and have your probe in long axis of the patellar tendon. And then as you move laterally, the next structure that you'll catch is that IT band onto that Gertie's tubercle. So that's kind of a good starting place. Otherwise, you can also palpate, use your palpation skills, and have the probe down just to confirm as well. So now looking at this IT band in long axis, you have your lateral femoral condyle, approximately tibia distally, and then it's this fibrous band here, this hyperechoic. You see the fibrils tight that go and attach to Gertie's tubercle. It's basically this thin fibrillar structure. It's hard to assess the two in anatomic layers with ultrasound, but it does, as you see in this picture, fan out as it inserts onto the tibia. So it's important not to confuse this with a sign of focal tendinopathy. It's really just how the fibers are attaching and inserting in that area. And in terms of cases where there's doubt, you can always use some local compression of the probe and see if it reproduces pain in patients with potentially tendonitis or this IT band type syndrome. Now looking at it in short axis, you can see it here on top of that lateral femoral condyle. In terms of pathology, what you're looking for, a lot of times for distal IT band tendinopathies, any sort of swollen band, any hypoechoic changes or loss of the fibrillar pattern, and kind of seeing if it reproduces their pain as well with sonopalpation. So next up, we looked at the menisci, specifically the posterior horns with the patient in prone. Now we have them sideline and we're looking at the joint line, and you can start off seeing the lateral meniscus. So you have your femur here and the tibia to the right. And then the triangular structure that's usually bright, hyperechoic, is the lateral meniscus. In this patient, you can notice that there is this linear dark line or hypoechogenic region, which really doesn't fill in upon dynamic scanning. So based on that, it was looking like there was a tear in this region. So you're looking for tears, you're looking for any sort of parameniscal cyst or hypoechoic clefts as well. And some of the meniscal cysts that you can see, it's when the lesions are filled with the mucoid fluid that's usually secondary to some degenerative meniscal tears. And then next up, in terms of having just another anatomy image, it's always helpful to see more of these as these tendons and ligaments transverse and attach. So the lateral collateral ligament or fibular collateral ligament, just seeing here in this orientation. So now as we see that, we'll go ahead and take a look at it under ultrasound. So it is going to have a little bit of a wavy appearance here. To help with that, you can make sure there's a pillow in between the knees, and then you have a little bit more of that varus production to kind of keep the LCL on tension. So you basically place the lower edge of your probe on the fibular head, and then rotate the upper edge anteriorly until you can get this view. And have it as elongated as possible. You'll start to see a little bit of the popliteus here, and then you're looking for this thin fibrillar structure attaching. So this is proximally, and then this is more distally as we see it attached to the head of the fibula. So you're really in this oblique coronal image, and you can have the knee kind of flexed and extended just to see how it changes as well. Usually in terms of looking for pathology here, if it's a torn ligament, you can definitely see it appear as a much thicker structure. And then the key thing to understand is with the LCL and the biceps femoris, there is some overlap as they attach. There's actually kind of in the literature, there's noted as like 5 types in terms of like the LCL passing more anteriorly, or if it's joining the long head of the biceps tendon, or the LCL passing more laterally to it as well. So just kind of understanding that if there's a little bit of mixed hyperechogenicity distally, that it may be because you're catching some of the biceps femoris attachments to the fibula, or even some of it to the tibia, depending on where you are in scanning. So you can also do a varus stress test and just see if there's any gapping or if there's any give with the LCL as well, indicative of a tear, or if you've already noticed laxity on physical exam, adding the ultrasound can give you that added benefit. So now in terms of the biceps femoris, this is that next part of the Z. You can see here the muscle and then it becoming tendon. So this is a little bit more proximally, and you have this myotendinous junction, and then this is more distally. So there are some fibers that insert onto the tibia, but then the rest attach to the fibula. You can look at this both in long and short axis. It is important to see this myotendinous junction because that's a common area of sport-related injuries as well. And then you can examine some of the posterior aspects of the lateral femoral condyle and kind of seeing the cartilage too as well. So then now in a short axis view, you can see the biceps femoris and its tendon here, as well as the LCL. And then as they come down and attach onto the fibula, you kind of see the interplay there where there can be a little bit of overlap. So once again, playing that, having your biceps femoris turn into the tendon, LCL here, and then they come down and then attach to your fibula. Other thing to make note of is you can have a fibella, which is just a small sesamoid bone, and that's seen in the tendon of the lateral head of the gastroc. So just something to note if you see this, not to think that, oh, it's a fracture, some sort of pathology. It can be the fibella or small sesamoid bone. Next up is the popliteus tendon. So just deep to the proximal part of the LCL, you'll see the popliteus tendon in this bony groove. You may see some anisotropy, so making sure you really wag the transducer and you can convince yourself and see if those areas are filling up and becoming bright again or if they stay dark. So this structure right here is the popliteus. In this patient, you can see some punctate hypoechogenic foci. And on the Doppler evaluation, you see some hyperuremia at those areas as well. So for her, looking at this with both of those findings is consistent with some tendinopathy in that region, which may have been explaining some of her symptoms as well. And then with the Popliteus, it is a tight turn. So when you try to turn on it 90 degrees in long axis, you can start to see it kind of curve around. And in terms of what it's kind of where it's going, it starts off in that area and then it turns around and it's going to go and attach to the tibia. And what we're looking for here is any sort of, tendinopathy again, any sort of tears as well, and understanding that there's there's kind of multiple components to the popliteus in terms of it mainly being extra-articular, but like intracapsular. Then there is part of it that's intra-articular as it traverses through. So making sure that there are some confounders, right? There's sometimes where you think, oh, yeah, this is more of a PCL cyst or fluid there, but it's actually coming from the popliteus. So making sure you can get more of a short and long axis view and try to follow it down. In terms of additional pathology that you can see here, there's times where there's case reports of having gout in the popliteus, even seeing pigmented villonodular synovitis or PVNS extending to the popliteus as well. And one study mentioned in general in terms of MRIs, getting MRIs of the knees, that popliteus injuries are detected in 1% of all MRI examinations. So it does pop up and oftentimes is associated with other injuries and pathologies within the knee. So next up, you can take a look at the lateral patellar retinaculum and the patellofemoral joint. So you have your patella here, and then the femur, and then right in between is going to be that retinaculum. And you can kind of dynamically scan and just looking to see if it looks bright, looks like it's tucked in the right area and location, and there's no abnormalities in that position. And then you can now also look at the proximal tibiofibular joint. So this picture, you have your tibia here, the fibula, and then right here in that area, you can see the joint, and the video kind of shows a more dynamic scan of it as it pops up as well. And this is the same view that you have to take a look at your LCL. So as you just move distally to the insertion, you can take a sneak peek at that joint, see if there's any big effusion or any cortical irregularities that you see as well. So for this patient, in terms of getting into the ultrasound report, looking at lateral knee, the main structures that were normal were the IT band, the LCL, biceps femoris, and common peroneal nerve. But looking at the popliteus, there's punctate hypoechogenic foci within the popliteus tendon in that groove with the associated hyperemia, which is consistent with moderate right popliteus tendinopathy. As far as the lateral meniscus, there's a linear hypoechogenicity and loss of that fibrocartilaginous architecture within the lateral meniscus, consistent with the lateral meniscus tear. And then the posterior elements of this patient's exam, the semitendinosus, semimembranosus, tibial, peroneal nerves were normal, and there's no visualized Baker's cyst. So overall impression from this ultrasound examination is that there's sonographic evidence of moderate right popliteus tendinopathy and a horizontal lateral meniscus tear. So in terms of results and outcomes, so we did get an MRI for this patient, and it did show the moderate popliteal tendinosis without tear. There was the complex, predominantly horizontal tear of the lateral meniscus with partial extension to the root. And then in addition, she did have some mild patellofemoral and lateral femorotibial OA and a small joint effusion. So it's nice to see that the MRI did match up with what we are seeing under ultrasound. And then we prescribed her a course of physical therapy, and she actually did improve. So that's good to see that we were able to target what her diagnosis was and to make sure she got the right targeted therapy for that as well. So in terms of some take-home points or Popliteus points, if you will, just understanding that there is that like extra-articular and like intra-articular portion. Here's another picture of the tendon as it enters the joint through the hiatus. So realizing that there can be more intra-articular pathology or extra-articular and having that understanding of the full breadth of the Popliteus. And then the big thing is knowing that it's rarely injured in isolation. So it's really important to be able to do this complete diagnostic ultrasound of that posterior lateral knee, because you can, in this patient, right, we saw the lateral meniscus tear confirmed on MRI as well. And not everyone is always going to come in and present with kind of the classic symptoms of like, oh, unlocking the knee hurts. Oh, it's like a sore muscle type pain. It was interesting that that's how this patient presented because I was like, oh, okay, so kind of more popliteus involvement. But she also had the meniscus there too. So just knowing that there's multiple structures in the area. And with that, I definitely want to acknowledge and thank my program director, Dr. Suhu, and Dr. Visco for all their teaching of ultrasound this year, and my co-fellow, Dr. D'Amico, for helping with images and this presentation, and having a wonderful year with this great team. So with that, I'll take any questions or comments.
All right, Lumi, thank you so much. That was a great job and nice work running through kind of that entire post-lateral protocol. And I think this really emphasizes the fact that like you can't just stick to, one thing. Oh, this is a lateral knee structure, so we're only going to image lateral knee. You really have to kind of take that clinical context into picture and go around, considering that joint space as one potential etiology as well. And you mentioned it, but I'm just going to mention it again. It's important to know that the popliteus is intracapsular but extrasynovial at the knee. And so while it is not, always contiguous with the space is not always contiguous with the articular surface, it frequently is. And so if you look at some of the like old arthrogram images, you'll see that when they do a knee arthrogram, the popliteus hiatus, will fill up with contrast. And so it can be very challenging, from a diagnostic standpoint. We rely, a lot on diagnostic injections, right, to diagnose things that are less clear or less common. And this can be challenging because an intra-articular injection might help, or popliteus injection may help an intra-articular problem because of flow. And so just, I think keeping that in mind with this particular tendon is very important. You highlighted a couple of things, but one of the first things that you said in the slide was, or in the presentation was, knowing where something starts and where it ends, and having that foundation of anatomy. I think that's something that, I at least personally emphasize with all of our residents and fellows is unless you know the anatomy, you're going to have a really hard time doing ultrasound because you can't just throw the transducer on someone's skin and say, I'm just going to find what I want to find. Especially in the posterolateral knee, you have multiple structures that run at slightly oblique angles. And if you don't really understand the anatomy of what starts where and ends where, it can be really challenging to figure out what structure you're actually looking at. And so I think that's just a reminder to everyone, doing this, like learn your anatomy, learn your anatomy, learn your anatomy. And when you really, really have the anatomy down, ultrasound becomes a lot easier to figure out. Um, you mentioned positioning for the lateral knee, and this is something that I struggle with. I move my patients back and forth probably more than they want to be moved, just based on like how things look to me and what I want. I typically have people start in that kind of lateral position, and then you can kind of like rotate their hip a little bit oftentimes if they don't have any hip problems to get that like more almost like a prone position while they're still side lying, and then you can kind of externally rotate their hip. And if you have a pillow between their knees, you can sometimes kind of bolster and position them where you don't have to do quite as much movement. And so that can sometimes be helpful. But if you're really getting to the posterior knee, you sometimes have to move people back and forth, which they don't always love. Other things that you did a great job on, I think, the popliteus is challenging, and you mentioned in a couple of different structures, like really trying to adjust your transducer positioning to bring out the best image you can possibly get. I think the popliteus is very susceptible to artifact, right? It's a curved tendon that changes directions abruptly and doesn't follow like a normal course that we expect a tendon to follow. And so really having that like, multi-positional imaging where you might not get the whole tendon in any one view. You might have to have several views at slightly different angles in order to bring that tendon in appropriately and eliminate any anisotropy, is really important. So as you get those images of the popliteus that you're showing here, kind of marching back through is really helpful. And then just for people who are maybe haven't scanned this area a lot, one thing I noticed on that top picture and associated with the other finding, you had the lateral meniscus tear. It looks like that joint space looks a little bit narrow to me, just very subjectively. And you see that osteophyte on the right side of the popliteus tendon. And those sorts of findings are ones that we frequently see with Popliteus pathology. So you oftentimes will see some version of like an osteophyte or a little loose body or something that's essentially putting a pressure point on that tendon as it curves around. And I think of it very similar to like a Haglund deformity, right? You have a pressure point on a tendon that normally follows a nice curved surface and shouldn't have any high pressure points. And so I think looking at those osteophytes really kind of clears up maybe partly why this is happening. In the other population, I see this very frequently in is knee arthroplasty patients. It's very, very common to have popliteus pathology in that particular group of people. And it very likely has to do with change in biomechanics, but also the implant components and any pre-existing osteophytes that may be in that area. And so just remembering to consider this pathology in that like painful post-arthroplasty patient. I think that's all I had. I'll open it up if anyone else has any questions or comments, but great work on this.
Yeah, Lumi, hi. Again, very thorough presentation. Is your thought, well, first of all, when you looked at radiographs, were they pretty normal to your recollection?
So she did have some mild OA when we got the x-rays for her, yeah.
Yeah. I mean, in my ex, I mean, well, the other question I have, what do you think is, and I don't know if there's an answer for this, what do you think the pain generator is? Do you think it's lateral compartment DJD, or do you think it's the popliteus tendon?
I think for her, it's definitely a mix of both, but in how she was describing things, it seemed like it was a little bit more like she described kind of the unlocking the knee or flutter kicks with swimming, and then she felt like it was always like a muscle type pain instead of kind of like sharp, like deeper in. So Initially, when she was just doing the history, I was like, oh, like, is this more like Popliteus? And like, given her age, I expected that she'd have some arthritis, but definitely a mixed picture, but it sounded like a little bit more of that muscle type pain for her.
Hmm. Yeah. When you first presented this case, at least in my experience, way at the top of the differential diagnosis is symptomatic lateral compartment OA. And I have found ultrasound to be really useful in this situation because oftentimes you can see findings before radiographic changes. And so it can be helpful. And so, and I know I've been redundant on this, but so when I start my lateral knee protocol, I always start anteriorly with the joint, looking for an effusion. And also in this case, and the clue that there could be some underlying degenerative changes is thickening of the suprapatellar synovial recess. So when you see thickening of that, oftentimes it's related to, an intra-articular process, in this case, probably developing osteoarthrosis. Um, so again, I always start my knee protocols anteriorly. Um, the, Recently, I have added to my lateral knee protocol the insertion of the lateral head of the gastroc. I have to shout out one of my colleagues, Allison Schroeder, who presented a case, interesting case showing a tear, and I'm always wonder how much I'm missing. So for now, I've added that just to look and see, if I see attritional changes or if it's more traumatic, I look for a tear. The other thing I've changed in my lateral protocol is, we get a fair amount of referrals to assess the common fibular nerve, and this used to be my lateral protocol, but now there's a nerve code. So now we follow the nerve, and I do include the common fibular nerve in this type of evaluation, but maybe not quite as detailed. Um, I just want to shout out or underline what Brennan said, and that is that one of the usefulness of ultrasound is to look at the lateral compartment and look for marginal osteophytes in DJD, which we do see in this case, both marginal osteophytes and degenerative type changes to the lateral meniscus. Because I found that DJD of the lateral compartment is a different beast. It can present with lateral, lower leg pain, posterior lateral pain. It can be very difficult sometimes. And I think, as in this case, the popliteus tendon is part of that whole process. The other thing to consider when looking at that image is that the lateral recess of the knee oftentimes will have fluid in it. So not to, you know, mistake that for focal fluid and an injury, but that is part of it. Where medially it's pretty tight, and we typically don't see fluid in the medial recess. We do see it in the lateral recess. And so when I've felt that I'm seeing symptomatic popliteus tendinosis, underlying again what Brennan said, it's usually knee osteoarthrosis or knee arthroplasty. And I would say knee arthroplasty by far and away is more common. And in my experience, what I typically see there is bony overgrowth at the prosthetic native bony interface. And with that bony overgrowth, it literally digs into the popliteus tendon. And so again, Brennan mentioned this, I will often perform the ultrasound guided anesthetic injection with a small amount of injectate into the popliteus tendon to try to sort out, is that the main pain generator? Realizing if you put a fair amount in, you're going to, also get some into the joint. So just kind of piggyback what Brendan was saying, I will often do selective injections to help sort this out, particularly if we think in a post-arthroplasty patient, this is a popliteus tendinosis. Um, but yeah, nice, very nice, thorough presentation. And like I said, I really feel that ultrasound has been very valuable above that of MRI in sorting out lateral and posterior lateral knee pain.
Doug, I'll ask you, do you inject into the popliteus tendon or adjacent to the tendon for diagnostic?
I inject into it.
Yeah,
Um, yeah, and I go proximal to distal long axis
yep,
when I do it. Is that what you do?
yes,
Yeah.
yeah. Okay, excellent.
If I'm, and I've actually injected a steroid in a post-arthroplasty patient, directly into that, thinking, well, release of that tendon ultimately is the is the solution if their symptoms become terrible, and actually they've done pretty well. I've been surprised that I've had a few patients respond pretty well to that.
Excellent. All right. Well, I think that'll conclude this for today. So thank you once again. That was a great presentation. Great job following kind of a good systematic protocol in the lateral knee. We'll be back on Friday, June 6th. We have Dr. Shane Geffey presenting on Liz Frank injury. Thanks, everyone. Have a great day.
Thank you.